नमस्कार, greetings from Apollo Group of Hospitals. मैं डॉक्टर शरद हूँ, कंसल्टेंट ENT head and neck surgery. The topic for discussion today is going to be hearing loss in pediatric age group. This talk is basically targeted at young parents, the first time parents. Basically, what is pediatric age group hearing loss? This type of hearing loss is very rampant in our society that we really are not aware of. The reason being, we have little ones at home, we are all happy having them at home, and then we really do not look at cues to whether they are actually listening to us or not. Many a times we stand in front of the kids, make faces, jump around, smile. They will look at us and also smile back at us. And we are happy that the child is listening to us, hearing us, and responding to everything. But what we need to know is when a newborn comes home, we really need to be sure if the child is hearing well. And that evaluation has to first happen at the hospital where the child was born. If it is not done in the first 1 month to 3 months of birth, it is mandatory as parents and the pediatricians to get a hearing assessment done for a young newborn. Now, what exactly does happen? Now, when we are born, we are all gifted with all our senses. But hearing sense is one that we really cannot make much about unless we get to know what the child is talking. Initially, it's just blabbering, those smiles that we are all happy about. But is our little one really listening? That is what we are looking at. There can be really myriad number of reasons to why a child may or may not hear. Congenital issues that can cause issues in the formation of the ear, the inner parts of the ear, the nerve of hearing, that the problems in any of these structures can cause hearing issues. That is one aspect of it. Now, there is another aspect where everything is fine. The ear is fine, the conduction of sound is fine, then the representation of the sound in the higher centers in the brain, that may go wrong. And that is very difficult to pick up. Initial evaluations can show that, okay, the child is hearing well, we've got no issues, everyone's happy. But there are instances with age, the child can have lessening of the hearing. And that is because there has been some mistake in the neuronal circuitry that connects the ears with the brain. So what do we do about it? That's very important. We get a large number of patients coming to us. What do we do about it? My grandparents tell me that my kid is not listening to me. My caretaker is saying that the child is not responding to sound. So what do we do about it? So the first contact that the child will have will be with the pediatrician. It is important for the pediatrician to look for the red flags in a child. It is not just hearing. It can be other senses as well. It can be delayed motor senses, delayed skill acquisition, delayed speech. And that is the most rampant thing. When a child does not learn to talk, the most common issue that comes up is he will learn in a couple of months. He will learn in a few weeks. My child learned it when he was 1.5 years. Yours will also learn. But that's not true in all the situations. So it's important that we really take our child as one unit, not because someone else has had a problem that we think that this is going to get sorted in some time or vice versa. So when a child meets the pediatrician is supposed to look for cues in the ear. If there's any blockage, any wax, any dirt sitting in the ear, that can cause issues in hearing. Or if a pediatrician will look at responses of sound, responses of the child to sounds while we clap or make sounds near the child without the child seeing us, and we look for the turn of the head towards the direction of sound. It is the directionality to sound that gives us the cue. It's not just the smile that comes, because the child can look at you and just smile at you, not because of what he or she has heard, but because of what he or she sees as movement, the colors around. That can make the child happy and smile, but that does not mean the child is really hearing. So the pediatrician looks in it, realizes, okay, there is some problem. Then the pediatrician is supposed to go back and look at whether a proper hearing, neonatal hearing assessment was done for the child or not at birth. It is important that if it is not done at the primary care center where the child is born, the parents are supposed to get it done in the initial 1 to 3 months of birth mandatorily, because this is going to be the yardstick for further investigations if need arises. So you're looking at a test called acoustic emissions. These are non-invasive tests which take only 10-20 seconds to give you results. So your child is not in pain while this is going on. You just have to have the child, a small machine is put up in the ears, which send out some waves, and we look for the responses to these emissions. In premature kids, many a times you cannot have proper responses to this particular investigation. So that is when we say that the test is a refer. And when it is normal, it is called the test is pass. Now, if you have a child, a full term baby who has refer, that means we wait for another 3 months to get a test done again. It is important to repeat the test after 3 months, because many a time there can be some more adjustment happening in the neuronal circuitry. But if you get two tests saying that refer, that means the child has to reach an ENT clinician, not an audiologist. Mind it, it's not an audiologist that he or she has to go to. It's going to be the ENT, because the ENT doctor is going to look for reasons to why it is so. If you have a child who is not growing well for any neurodevelopmental issue, you can certainly have hearing issues as well. So in that situation, we really need to know if we need to get a neurodevelopmental pediatrician on board or not, a behavioral psychologist to look into the child or not. So this is important, that we evaluate the child globally. Now, there is a lot of resistance to parents understanding this problem. That is where we have so much of social burden in terms of pediatric hearing loss in our country. The parents resist the idea that there could be something wrong with the baby. No one wants to go through that pain, but it is important that we try to find the problem at the earliest so that we can intervene at the earliest. Intervention can be from providing hearing rehabilitation, explaining the parents that the hearing rehabilitation is not going to work because the neuronal circuitry is not functioning. Then we have surgical interventions which aid the child to hear better, so that the child can get more accustomed to the social environment. It is important that we look into these matters sooner, before the child enters the school, goes into the college, because there is a lot of social peer resistance to the idea of having something up in your ears, behind your ears, that causes the child to underperform socially and emotionally, as well as academically. So the sooner we intervene, the better it is for all of us. The whole idea of having this discussion is to bring all the first time parents and all the parents generally to understand the importance of neonatal hearing assessment. The past decade or so, India has been very good at maintaining a good record at neonatal hearing assessment. That thanks to all the tertiary care centers, we've been doing good, and our data is improving, but there is a long way to go. There are areas around this country where people do not know about the importance of hearing loss in pediatric age group. So the talk today is basically aimed at enhancing neonatal hearing assessment in our country so that we can pick up early cases of pediatric hearing loss. After we've understood all these things, I think it's a good time to discuss few questions that come up while we discuss neonatal hearing losses or pediatric hearing losses. The most common question that comes up is, why my kid? I always try to tell the parents it's not your mistake, it's not the child's mistake. It's just that it is like that. But then what is more important is what can be done about it and how soon do we need to do it. When it comes to the duration or the time of intervention, it is important for all of us to understand that our brain is constantly growing. We are giving inputs to the brain, and the brain is modifying day in and day out. And in that situation, we must understand the first 2 years of birth is the period where we need to learn to get our people to intervene. Not beyond that. The success rate of any intervention beyond 2 years is going to be difficult. It is going to be hard because there is something called neuroplasticity, which means that the brain is most receptive to new changes and information in the first 2 years, beyond which the hard work is going to be doubly more in terms of getting the child to understand what is being told, how to respond, skill acquisition, everything is going to be important. So that is the first thing. Next most common question is, what is the role of an audiologist or a speech language therapist in neonatal hearing loss? They, to be very honest, the surgeon takes up 30-35% of the job. The rest is the speech language therapist and the audiologist who help us in fixing the problem, and also the parents who are actively involved in hearing enhancement in a child who's lost it. The audiologist and the speech language therapist look into the problem, tell the parents how to go about the problem and how to learn new things. There is a psychologist or a behavioral assessment group who looks into how well the child is maintained in the domestic situation. You cannot have a child with problems sitting in front of a tab or a TV the whole day. It's not going to do any good. You cannot have a child at home, parents away with a caretaker who is not even looking at the child. That's not how it's going to work. If there is any intervention that has to happen, it will be done at the end of the surgeon, and the rest of the game is totally by the speech language therapist, the audiologist, and the parents, grandparents. Without domestic support, without parental support, this war is lost. For us, it's easy for us to say that we will operate and the child is going to be okay. But I must again reiterate the fact that it's never the surgeon. It's always the team effort that comes in first. The parents, the situation around at home, and the speech language therapist and the audiologist. If we are looking at a milder form of hearing loss, what can be done? So that's the most relevant question. In that situation, we need to know how adapt the child is to mental situation, to social environment, and we can start off using hearing aids. Even if the child is in for a cochlear implant or some extravagant surgery at a later point, you cannot say that let me get some money ready and I will do it when the child is 10 years of age. You are depriving the child of auditory stimulation all that while. And if you decide, or if any parent decides, or if any surgeon decides that a hearing surgery done with a cochlear implant at 10 years of age and the child is deprived of sound all that while, the implant surgery is going to be zero result, because all that while the child has had no auditory stimulation. The brain is like, it's like a large pasture. If you give it the best of the stimulus, it will learn. And even if you can't, I know the cochlear implants are very expensive, but you can still buy some time by giving hearing aids, by improving these auditory stimulus for the kids. What is the burden of this problem? We've seen kids who come in, parents, when they are in their college, when they have got really bad social performance, academic performance, worried. And that is a very difficult stage to be in for the parents, for the child, the patient, and the doctor. Because at that point of time, we really cannot offer much. And that is why it is of utmost importance that we intervene as soon as possible where we can do the best for our kids. I think this briefly brings up everything that we know about hearing loss in pediatric age group, what has to be done. So, the whole purpose of this discussion today is to make people aware that this is a common problem. This is a problem that can be handled when given or provided we do it at the right point, and we can really bring up our kids as good as normal kids if there is a problem. We are open to any queries and suggestions as and when you require. Thank you.